hepatocellular pattern on LFT testing. And the name sort of gives that away, autoimmune hepatitis. Hemochromatosis, remember, is also associated with a hepatocellular type pattern on LFT abnormalities. It talks about the bronze diabetes that we talked about. And it also reminds you that it's associated with an infiltrative cardiomyopathy. So that infiltrative restrictive cardiomyopathy. Wilson's disease, also associated with hepatocellular type pattern. I showed you the Kaiser-Fleischer rings, which is the board question for Wilson's disease. Wilson's disease is also associated with a tremor, and I think we probably mentioned it. I don't remember if we mentioned it when we talked about neurology. It's not in the book, but I have it in my supplemental notes that when we talked about the basal ganglia, we talked about Parkinson's disease, we talked about the different types of tremor. And you mentioned that Wilson's disease could be associated with a postural tremor. So just refresh your recollection about that. And again, it matters because if you see a patient in whom, let's say you're considering the possibility of, these things aren't common, but let's say you see a patient in whom you're considering the possibility of a disease like hemochromatosis or Wilson's disease, if there's something that is there on physical exam, you want to look for it. And you want to say, I look for it. It shows the preceptor that you understand the pathophysiology of the disease. Okay? They mentioned the last topic that they talk about is hepatocellular carcinoma. They point out that hepatocellular carcinoma, the risk of hepatocellular carcinoma is increased with any disease that causes cirrhosis, but that and it's also associated with certain carcinogens. They mentioned aflatoxin. Aflatoxin is a mycotoxin that's produced by fungi, by Aspergillus, and it's found in certain spices, certain nuts, and certain cereals. And again, one of the tests that can be done to look for this, besides obviously imaging tests of the liver, is alpha-fetoprotein. To point out though that if you find a patient that has a mass in his liver that's cancerous, the patient is more likely to have metastatic disease than it is to have primary liver cancer. That's true of the liver. It's also true of the brain. Right? If you find a tumor in somebody's brain, the statistical likelihood is that it's coming from somewhere else, and it's a primary brain tumor. Right? Okay. The next topic that they talk about is portal hypertension. And we alluded to this a little bit before. Do you remember which disease is associated with portal hypertension? We talked about it in GI. Portal hypertension causes esophageal varices. Okay, and so let's talk a little bit about why that happens and the approach to the patient with portal hypertension. If you look at figure 412 on page 85, what you'll see here's the Okay, so if you look at figure 412 on page 85, you see that the approach to the patient with portal hypertension, patients with portal hypertension can be divided up into either prehepatic portal hypertension or intrahepatic portal hypertension or posthepatic portal hypertension. We'll talk about each of these in turn. So prehepatic portal hypertension refers to diseases that are associated, for example, with thrombosis of the portal vein. But what you're most likely to see in clinical practice are intrahepatic causes of portal hypertension. And cirrhosis is the thing that's most likely to come across your path. So patients that have cirrhosis for whatever reason, chronic viral hepatitis, alcohol abuse, whatever, those patients are said to have intrahepatic portal hypertension. I'm going to talk about portal hypertension in a second. And then finally, the last category of hypertension, portal hypertension, are posthepatic causes of portal hypertension. And those are associated with, for example, problems affecting the hepatic vein. So, for example, thrombosis of the hepatic vein. We point out patients that have right heart failure or restrictive cardiomyopathy, restrictive pericarditis. In all of those people, what's going to happen is that there's going to be increased pressure in the inferior vena cava, which is going to be transmitted to the hepatic vein. Okay? All of those you're going to have posthepatic hypertension. So let's look a little bit at portal hemodynamics, which I think we looked briefly at before. But the portal pressure is the portal venous flow times the resistance to the outflow. And they point out that the normal portal pressure is 5 to 10 millimeters of mercury. We talked about this when we talked about esophageal varices. You have two outflows from the portal system, two resistances in parallel. The first one is due to flow through the portal vein, the liver, and then the hepatic vein. The second one is due to flow through collaterals from the portal system that drain into the systemic circulation. And those collaterals exist at the level of the gastroesophageal junction, and they exist in the rectum, okay? And they also exist, the periumbilical vein. So patients that have portal hypertension, they can develop problems with venous esophageal varices, venous hypertension, the dilatation basically of these collaterals, which can manifest as esophageal varices, hemorrhoids, Okay, now not everybody that has hemorrhoids has cirrhosis. Okay, in fact, most people who have hemorrhoids just need a better diet, but you can see hemorrhoids in patients that have cirrhosis, and then they can also develop. The other finding that these people can develop is that caput medusa. That they show you caput medusa in physical diagnosis. It is a manifestation of the same phenomenon. If you get an idea, if you have the marked dilatation of the superficial veins right there. Okay, and that's again collateral in a patient who has portal hypertension. So portal hypertension, the book points out, it can occur acutely or it can occur chronically, it can occur slowly, insidiously. And how the patient presents is going to depend on how this unfolds. So, for example, if you have a patient who, let's say, suddenly thrombosis of the hepatic vein, let's say sudden thrombosis of the hepatic vein, that person has Buch-Chiari syndrome, and if they have sudden thrombosis of the hepatic vein, they can present with fulminant hepatic failure, which is liver failure. Whereas if the process develops more slowly, instead of presenting with fulminant hepatic failure, they can present with the slow development of portal hypertension. They can develop ascites and esophageal varices, and all those places that we talked about. So how they present depends on how the disease develops. Okay, did they develop whatever process caused the portal hypertension? Did it happen suddenly or did it happen gradually? Okay, gradually you're going to see venous hypertension, ascites. Suddenly you may see fulminant hepatic failure. Patients, for example, that have Buch-Chiari syndrome, if they present with fulminant hepatic failure, most people need to be treated expeditiously. They're sometimes treated with thrombolysis, sometimes they're treated with shunting, anticoagulation, etc. All right. Any questions about that before we talk about ascites, which can be seen in patients that have pulmonary hypertension, although they can have it for other reasons. So we're going to talk about the topic of ascites in general, and then specifically as it relates to portal hypertension. Remember some of the other conditions that can be associated with ascites besides portal hypertension? Some of the stuff. Huh? Well, hepatopulmonary syndrome is because they have ascites. But why do they have ascites? What are some of the causes of ascites? Huh? A problem with the bowel? Like what? No, I mean they'll get distension, they'll get abdominal distension, but not usually ascites. But that, yeah, remember, right heart failure is going to produce low extremity edema and ascites as well. Absolutely. So that's good, and you can get it nephrotic syndrome. So there's different, in some degree of ascites, but right heart failure certainly. So let's talk about ascites. The book points out that cirrhosis-induced portal hypertension is the most common cause of ascites. So you'll see this when you start seeing people in the hospital. You'll see, I'm sure, lots of alcoholics who have ascites. And the approach to the patient with ascites, in order to evaluate the patient with ascites, the way those people are evaluated is by sampling the fluid, the acidic fluid. The amount of fluid you can get quite a few liters out of somebody who has a marked ascites. Sometimes ascites is not so visible not so apparent and maybe difficult to appreciate on physical exam. Sometimes you can only visualize it by doing an ultrasound or some other imaging process. But if you're dealing with somebody that has visible, obvious ascites, and you want to know why do they have the ascites, one way to do it is by sampling the fluid and studying the fluid. What you're going to send the fluid for, you're going to do a paracentesis, and you're going to remove some fluid for studies, and you're going to send it for a cell count to make sure that they don't have an infectious process that's involved. Because patients that have, for example, liver disease and cirrhosis are prone to the development of something called spontaneous bacterial peritonitis, where that fluid can become infected. Okay. So you want to make sure that they don't have peritonitis. You want to send it for a gram stain. You want to send it for acid-fast bacilli to make sure that they don't have tuberculosis that's responsible for the ascites. Amylase, because sometimes pancreatitis can be associated with ascites. You want to send it for a culture. That goes with the gram stain and the cell count. And you want to send it for cytology, because sometimes patients can have intra-abdominal malignancy. They can have carcinomatosis, abdominal carcinomatosis, with carcinoma spread throughout the abdomen, especially, for example, females that have, let's say, ovarian tumors or metastatic cervical cancer. So you want to look for those things as well. But the other thing that you're going to send it for is you're going to send it for chemistry. And you're going to calculate something called, as the book talks about in their notes, the serum ascites albumin gradient. And basically what you're looking for is you're looking for the concentration of albumin in the serum, and you're comparing it to the concentration of albumin in the ascites. Okay? This is sort of like what you did with chlorophyll, okay? And the closer those two numbers are to each other, the less likely, the closer that those two numbers are to each other, the less likely it is that you're dealing with portal hypertension. Because think about it. What you expect to see in somebody that has portal hypertension, that's going to be the equivalent of heart failure. Okay, in terms of chlorophyll. Let's think about what's happening at the level of the capillaries. Okay, so you have the capillaries. And remember, you have hydrostatic pressure tending to push fluid out into the interstitium. Okay, and then oncotic pressure tending to draw it back in. Right. So if somebody has portal hypertension, then this is what's going on. Okay? The hydrostatic pressure is very high. It's pushing fluid out into the interstitium and ultimately into the peritoneum. Well, that fluid is going to be rich or poor in albumin. Poor in albumin. It's going to be basically just fluid. Okay? And so you'd expect that the serum albumin would be much higher than the acidic albumin, the albumin in the ascites. Whereas if they have a process such as an infection or some inflammatory process that causes leaky capillaries, then you're going to get albumin is going to leak out into the peritoneal fluid, and as you can see in the book, then the serum albumin ascites gradient is going to be less than 1.1. Okay, so serum ascites albumin gradient greater than 1.1 is portal hypertension. If it's less than 1.1, it's not portal hypertension. Questions about anything that we talked about so far?
Yeah. Would you do an amylase from the blood work as well if you have any inkling of pancreatitis? Would that be something to consider?
Yeah. Yeah, and we will. The next topic that they talk about is varices, and they in their discussion they do talk about the development of caput medusa because of the periumbilical collaterals. They talk about the development of enlarged hemorrhoidal veins. They talk about the esophageal varices, which we've talked about. They also talk about the development of hypersplenism, which I think you guys probably have learned a little bit about physical diagnosis and probably learned about it in CMS or will shortly. But basically, patients that have portal hypertension develop splenic, they can develop splenic enlargement, and they can develop abnormalities associated with that. So, for example, they can develop pooling of blood products in that enlarged spleen, which is going to be reflected with thrombocythemia, maybe anemia, and neutropenia. We talked about esophageal variceal rupture and the association with upper GI bleed and the approach to that. They do talk here about how if the patient survives. I showed you the survival curve, and I showed you that it's not a very good survival curve. But that if they do survive, they can be treated with beta blockers to lower the portal pressure, try to lower the portal pressure, and decrease the incidence of rebleeding associated with esophageal varices. They can also have the esophageal varices banded. They can have sclerosis. So there's different interventions that they can do. They can have ligated, and they can have a shunt created hip shunt. Anyway, CRTS, to put a shunt in. The thing you need to be aware of is however, is that whenever you shunt somebody to decrease portal hypertension, to decrease the portal pressure, you have to pay, you have to rock here to pay Paul. And so when you shunt somebody to deal with portal hypertension, you make the hepatic encephalopathy worse. So if somebody has hepatic encephalopathy, because you're increasing the shunt. So if somebody has hepatic encephalopathy to begin with, it's probably not a great candidate for shunting. Okay? So shunting, what's going to limit the shunting is going to be hepatic encephalopathy. Because again, you're bypassing the liver. And if they're already encephalopathic because the liver function is so bad, then the more you bypass the liver, the worse the encephalopathy develops. Oh, there it is. Transjugular intrahepatic portal systemic shunt. It's in the discussion. Okay. Let me talk just briefly about the acute management of esophageal varices. They can have endoscopic, they can undergo endoscopic variceal ligation. So at endoscopy, they can ligate the bleeding varices. They can be injected with a sclerosing agent. They can be treated with octreotide or somatostatin. We'll talk more about somatostatin later on when we talk about endocrine pathophysiology. But somatostatin has a vasoconstricting function, and so you're taking advantage of that vasoconstricting activity to try and clamp down on the varices to try and get the bleeding to stop. We talked about the transjugular intrahepatic systemic shunt that they can be subjected to. And the other thing that you could do is something called a balloon tamponade. And this was all that you had available in the old days. I'll show you a picture of it. Okay, well this picture here shows you basically what's going on. You have a tube put down the esophagus, and you have this couple of balloons, one here and one here, which when they're blown up is going to tamponade any bleeding esophageal or gastroesophageal varices. Okay, and so typically what would happen in the old days where there really wasn't a whole lot to do if somebody came in with bleeding esophageal varices in the middle of the night. I remember many times going to work in the morning at the city hospital. These were people who didn't have private rooms. They had big wards, so they might be a room like this with like 20 beds in it. If you get people for privacy, they'd be like shower cups around his bed. So what you find a person in bed, hopefully it looks low patient, and you have the tube coming out of his nose, and somebody had like thrown it over the shower curtain, the shower rod, and then there was like a bottle or a bag of saline hanging to put some weight on it, and that was the weight of the saline was tamponade those varices. And then it was like, all right, well, called GI. But yeah, that was pretty dramatic. It's looking like you picture somebody like that. But yeah, now you get GI right away. You do all kinds of good things with tips and octreotide and sclerotherapy and ligation. So it's a new day. All right. Any questions about any of that before we talk about diseases of the gallbladder, bile duct? Okay, and actually, for the elevated alpha phosphatase, and again, you can look at the GGTP to see whether you're dealing with bony boards or liver boards. Okay. Okay, so the first thing that we're talking about is cholelithiasis or gallstones. And there's two different kinds of gallstones. There are pigment stones, which can be brown or black, that result from bilirubin breakdown. And then there are cholesterol stones. 80% of gallstones are cholesterol stones. About 20% are pigment stones. Patients can develop pigment stones if they have anything that predisposes them to the development of hemolysis. So, for example, sickle cell disease or some chronic hemolytic process is going to predispose them to the development of the pigment stone. But again, most of the stones are going to be cholesterol stones, and the things that predispose people to the development of cholesterol stones are listed in the mnemonic: female fat 40, fertile. There's one more: female fat 40, fertile. Huh? I can't hear you. Yeah, I know, but I think there's a fifth one, but I can't remember now. But I don't even know if you could use this mnemonic anymore. I mean, it's probably considered really sexist, you know. But those are okay. So let's talk a little bit about the gallstones and what happens. Female total fat. Huh? I don't know. Okay. Anyway, so let's talk about some of the things that can happen in terms of gallstones. So most of the time, patients that have gallstones are asymptomatic. Okay, most of the time they're asymptomatic, but over 10 to 15 years, a certain percentage will become symptomatic, 20%, whatever. And the rule is that once they become symptomatic, the complications increase in severity. So once they start to develop symptoms, the symptoms tend to become worse and the complications tend to become more severe. So let's talk about the things that can happen. The things that can go wrong. Okay, so for example, here's the asymptomatic gallstones over there. Okay, if they become lodged in the cystic duct, patients can develop acute cholecystitis. If they become lodged in the common bile duct, then they can develop. By the way, stones that are present here, that's referred to as choledocholitis. It refers to gallstones in the common bile duct. And patients can develop different problems if they develop here. So, for example, patients can present with biliary colic, nausea, vomiting, pain, which is not really a causative pain, so it's kind of a misnomer. Or they can develop the more serious condition of ascending cholangitis, which is biliary colic associated with fever and jaundice. And it makes sense that for them to have jaundice, the stones have to be located distal to the liver, right? So the stone there is not going to produce jaundice, okay? The stone there is not going to produce jaundice. It has to be distal to this bifurcation, okay? Over there. So they can develop biliary colic, or they can develop ascending cholangitis. And they point out that if the stone passes all the way down, and then let's say it increases in size and it gets lodged here, or let's say that the sphincter is very tight there, okay, the sphincter of Oddi is tight. If it gets lodged here, then the patient can develop gallstone pancreatitis. Okay, so the stone is going to block the pancreatic duct, so it's going to block pancreatic secretion, so you're going to get the pancreatic enzymes are going to start chewing up the pancreas. So, acute cholecystitis, biliary colic, ascending cholangitis, gallstone pancreatitis, those are all possibilities. Another possibility is they point out that the stone can pass into the duodenum and obstruct, leading to gallstone ileus. So this is the biliary colic. Again, it could be associated with a temporary obstruction of either the cystic duct or the common bile duct. So again, it could be there or there. Either one could produce a biliary colic. Okay. Again, it's a misnomer because it's not associated with particularly colic type of pain. Pain is generally the right upper quadrant, radiates to the right shoulder, irritates the diaphragm, right scapular region, associated with nausea and vomiting, and it resolves spontaneously, and sometimes with nitrates. Okay, so remember we said that nitrates, which are given to treat what we think is cardiac pain, we said that nitrates are really not specific, and sometimes they make the pain of other things better. What was the other thing that we said nitrates can make better? Remember? Yeah, esophageal spasms. So retroactive esophagus sometimes can respond to nitrates, and sometimes a biliary colic can respond as well. And again, if it's radiating to the right shoulder, to the right subscapular region, you might mistake it for the cardiac pain. You certainly want this cardiac disease. Acute cholecystitis, again, is going to be associated with lodging of the stone there. Again, it can begin as biliary colic, but the pain becomes more severe, they can develop farting. And again, what you're developing is an infection behind the stone. If you have a stone here and you develop an infection behind it, it's acute cholecystitis. An inflammation behind it, it's acute cholecystitis. If you have a stone lodged here and you develop an infection behind it, it's ascending cholangitis. It's a more serious infection. Okay? So this is just showing ultrasound of the patient with acute cholecystitis. Visualizing the stone and the edema of the wall. Okay. Common bile duct stones, again, can give rise to biliary colic, can give rise to ascending cholangitis, and the triad that indicates ascending cholangitis is biliary colic associated with fever and jaundice. How do you find stones there, okay, in the common bile duct? You can do a transabdominal ultrasound. That's the easiest thing to do, and it's what's usually going to be done initially. But the further down in those ducts that those stones get, the more harder it is to visualize them. And so another thing you can do is you can ask the radiologist to do an MRC or a magnetic resonance angiography. If you still suspect that you're dealing with a common bile duct stone, and you can't see it on ultrasound, this would be the test that you would ask the radiologist to do. And this is an MRCT. Who has abdominal pain and jaundice. This is the common bile duct. I guess it's dilated here. Okay, it's a little bit. I would guess it's dilated. I don't know, but it's generous here. There's a filling defect, which I guess is stone, and then they're saying there's a picture here, which I guess is why the stone got stuck. Okay. Gallstone ileus. Again, the way that this happens. The way that the gallstone ileus happens is if you have a stone here that, you see these two structures are contiguous, okay? And so if you have a large stone here that, let's say, you get inflammation and these two serosal surfaces maybe stick together, and then the stone can actually erode through the wall of the gallbladder and through the wall of the bowel, and it actually can enter the lumen of the bowel. And if it's big enough, it can cause obstruction of the lumen. You get a gallstone ileus or CT scans that if a woman's small bowel obstruction due to gallstone ileus in the left panel, free air is seen in the biliary tree, so it's there, and the gallbladder, and then the right panel, which is a dilated root of the small bowel with a large gallstone with a calcified rim. So there's the gallstone, and here's the root of the bowel, and see it's filling the lumen. The problem. Okay, just supplemental, talk a little bit about the remaining topics. They talk about cholangiocarcinoma, the cancer of the bile duct. They point out that it's associated with parasitic. I've seen one case as far as I know, I've seen one, maybe two, but one that I remember was when I was training, and it was a woman from the Caribbean. Anyway, it's associated with parasitic infection, for example, liver fluke in Southeast Asia. Patients that have gallstones are also predisposed to the development of gallbladder cancer, and its presentation mimics cholecystitis. You should also suspect the development of cholangiocarcinoma in patients that have long-standing ulcerative colitis with sclerosing cholangitis. When we say sclerosing cholangitis is a complication of ulcerative colitis. Complication is a complication. Is the development of cholangiocarcinoma. Sometimes patients who have ultrasounds are noted to have polyps in the gallbladder. And the question is, how do you know whether somebody has a gallbladder polyp? How do you know whether it's a benign gallbladder polyp or whether it's a polyp that's in the process of becoming malignant? And apparently the only reliable way of distinguishing them is by the polyp size. So the recommendation is that if you have any polyp that's a centimeter in size or larger, that polyp be removed. And I don't know. I'm not sure about if they have a centimeter, does that person warrant follow-up? I don't know. I'd have to look that up, or I'd have to ask one of the GI doctors what they do with people like that. Is that worth following up, or forget about it, or what? I'm not sure about that. But if it's a centimeter or greater, then you take it out. And these people, if they have carcinoma in the gallbladder, these people do terrible. No frequency of therapy agents in the gallbladder. Overall survival is 5 to 5%. It's dismal outcome. In terms of the inflammatory diseases of the biliary system, we talked about primary biliary cirrhosis. It's an autoimmune disease, and we talked about how it presents with a cholestatic picture in terms of LFT abnormalities. And it can be recognized serologically with antimitochondrial antibodies. You don't see those in primary sclerosing cholangitis, but antimitochondrial antibodies are a marker for primary biliary cirrhosis. Primary sclerosing cholangitis, we said, is associated with inflammatory bowel disease, particularly ulcerative colitis. We talked about the association with the development of cholangiocarcinoma. And the treatment of this condition, once it becomes, there's no treatment for it, so that basically the treatment is liver transplant. Okay? Again, it's associated with fibrosing destruction of intrahepatic bile ducts. Most of the time, 75% ulcerative colitis. It can antedate the onset of inflammatory bowel disease, which means that you can have a patient come in with an obstructive or hepatocellular type, with a cholestatic type picture in terms of the LFT, and you ask the question, do you have ulcerative colitis? And they say no. Well, they just haven't developed the signs and symptoms of the ulcerative colitis yet, but they will. Okay, so they can again have abnormal liver chemistry, elevated oxygenation. We talked about that. They have symptoms, pruritus related to the elevation of the bilirubin that we talked about. Same thing. And they can develop cholangitis, you might imagine. If you develop obstruction in the biliary tree, whether it's from a stone or stricture, they can develop an infection behind it. And again, you can visualize it by MRC scanning, which we talked about before. So this is the person cholangiogram of patient with primary sclerosing cholangitis. Market these abnormalities. All right, I don't want to rush through it. What I'm going to do is I'm going to finish up the GI stuff next time we're together, because we have, I think, we have 2 sessions on hematology and then 1 lecture on rheumatology. Okay, and so I'll finish this stuff up before we do the hematology. The other thing I want to make you aware of that you guys can take a look at before we get to, if you want to take a look at it before we get to the rheumatology stuff, you might want to I think the American Rheumatology Association, they have their website. They have free resources, free educational resources. I think you can Google. I think it's called like high impact rheumatology, and so they have a whole bunch of resources of the things that you're most likely to see in clinical practice that relate to rheumatology. Really good educational resources to look at. The book is okay, but it's just kind of brief. So you might want to take a look at that. What was the question you had in the back? You're gonna have what? All right, I'm gonna have to talk with them about that, because you have there's 3 more lectures you have to have before you have to do the test. So I'll talk with them about that. And who showed me the mnemonic at the break? Somebody showed me. Oh, you want to tell them what the mnemonic is for the for how you remember alcohol and how it's associated with LFT abnormalities? Okay, a Scotch and tonic, AST. You see an elevation in the AST predominantly in patients that have hepatitis C through alcohol, as opposed to like a balance between AST and ALT in patients who have other causes. All right, so I'll talk with them about that.
I just wanted to say thanks to you and let the class know that you and Dr. Patch both said Friday was cool. So Friday we're going to do 8 to 10 patho quiz, 10 to 12 to debate, so that everyone's done with it.
Great.
Okay. Thank you.
Well, you, Dr. Phil.